these diseases are very common, and understanding their pathophysiology, their management principles is really paramount for all people who are in healthcare. Cardiovascular diseases in general involve alteration in the heart and blood vessels, including the associated change in blood flow. The most common conditions that you come across in clinical practice are hypertension, coronary heart disease. Then there is heart failure, when the heart is unable to meet needs of the body, so it fails as a pump. And then we have cerebrovascular accidents. Looking at some of the numbers, approximately 18% Australians have a chronic cardiovascular disease, and this incidence increases with age. It causes 34% and 40% of deaths in Australia and New Zealand respectively. So cardiovascular diseases as a whole afflict a lot of people, and they cause a lot of mortality as well. Okay. There is recent decline in mortality due to cardiovascular diseases, which is a fruit of better management of the disease and decrease of some risk factors. For example, there's more awareness around smoking as a risk factor, so there is some decline in smoking. But at the same time, there are factors which are counterbalancing this. So the increase in the aged population, elderly, obesity is something which is increasing, diabetes mellitus. So let's look at hypertension as our first topic. In Australia, 30% adults over the age of 25 have hypertension or are on antihypertensive drugs. So this is a very high number. Many people are likely to have undiagnosed hypertension as well. How do you diagnose hypertension? It has to be based on repeated measurements. You can't diagnose someone as being hypertensive on one single measurement, right? Because just the apprehension, of being tested for blood pressure could increase the blood pressure in the patient. So you can't rely on single measurement. Repeated measurements where systolic blood pressure is above 140 millimeters of mercury, or diastolic is above 90 millimeters of mercury. And these readings should be on a different day and at a different time of the day. Repeated measurements before you can label someone as being hypertensive. Different blood pressures are classified into diagnostic categories with respective recommended interventions. All right, now major parameters of blood pressure control. Blood pressure is determined by two major parameters: cardiac output and the total peripheral resistance. What determines cardiac output is heart rate and stroke volume, right? What determines total peripheral resistance is the tone in the arteries and mainly in the arterioles. What determines stroke volume? Preload, afterload, contractility of the myocardium itself, right? What determines all of them? You have sympathetic nervous system, renin, angiotensin, aldosterone system. There are other neural, hormonal, and local regulators of blood pressure as well. So it's a very complicated regulatory mechanism for blood pressure. Okay. Now, hypertension causes increased risk of myocardial infarction, kidney disease, stroke, and many other conditions. 90 to 95% of hypertension that you find in population is primary, which means you can't find a specific cause of hypertension. So it's also called idiopathic. And the understanding now is that it is a multifactorial disease. You can't pinpoint a single factor responsible for primary hypertension. In 5 to 10% of hypertensive patients, it could be secondary hypertension, where you can find a cause of hypertension. For example, there's a kidney disease. Kidney is making too much renin. So you end up having too much aldosterone and angiotensin too as a result. Okay, adrenocortical, there are certain drugs which can lead to development of hypertension. So wherever you can find a pinpoint cause of hypertension, that is secondary hypertension. There are many risk factors for primary hypertension. So it's family history, age and gender. So as the age increases, increased chances of hypertension. Males have a higher chance of having primary hypertension. Abdominal obesity, heavy alcohol intake, glucose intolerance or diabetes, okay? High salt intake, sedentary lifestyle, low potassium, calcium or magnesium in the diet. So all these are risk factors for primary hypertension. What are the mechanisms of primary hypertension? So it is a result of alterations in neural, hormonal, and local controls. Other contributing factors could be inflammation, insulin resistance, or procoagulant factors. So all these mechanisms will lead to the outcome of chronic hypertension. So when hypertension is there for a long time, this would lead to some permanent changes. So there would be vascular remodeling, there would be renal changes, and there will be cardiac hypertrophy, right? Why do you think in chronic hypertension you will have cardiac hypertrophy? Heart muscle has to work harder to overcome the afterload. So in hypertension, the afterload is increased, right? The pressure against which ventricle has to pump blood has increased. So there is increased afterload, and as a result, when this goes on for a long time, there is compensatory change in the muscle fiber, so they have hypertrophy. In systemic hypertension, there is left ventricular hypertrophy. All right. Primary hypertension, multifactorial disease. There could be genetic influences. Family history is important. Environmental factors could be many. So it could lead to either simple functional vasoconstriction, so the vessels are constricted. It could lead to defects in vascular smooth muscle growth and structure, and there is increased vessel wall thickness, right? So these two possibilities. The third one is there's defect in renal sodium homeostasis. So kidney is reabsorbing a lot of sodium and a lot of water, increasing the ECF and plasma volume. So there is increased volume, increased pressure. Okay, all these will lead to hypertension. All right. How patients present? Early in disease, there are no signs or symptoms. It's a silent disease. Okay. Later on, symptoms arise due to associated damage of organs as well as vascular changes. So as you can imagine, hypertension would be symptomless for many, many years, because it takes many years for these complications to develop. And that is the reason why sometimes it is called a silent killer. How it may present? It may present as heart disease, okay, renal insufficiency, brain dysfunction, impaired vision, impaired mobility, vascular occlusion, and edema. Right. So for this reason, regular screening of blood pressure is important, so you pick up hypertension early in its course, and you can prevent some of these complications. So evaluation is by repeated measurements of high blood pressure. You take history from the patient, do physical examination. You can also look at electrolyte levels, urea, creatinine, hemoglobin, fasting glucose, cholesterol levels, LDL, HDL, and I will explain these later when we talk about atherosclerosis in more detail. Okay. You can do urinalysis. You can do ECG. ECG again will not show you anything in early hypertension. It will show you when there are complications. If there is ventricular hypertrophy, if there is heart failure, then ECG will pick up something. So most of these investigations will return negative in the early stages of hypertension. So they will actually pick up the complications of hypertension. How do you manage? The first and foremost is non-pharmacological management. If you diagnose hypertension early, then there are lifestyle regimens. If you have to resort to pharmacological measures, which means the lifestyle changes do not bring the blood pressure down, then you start treating. What can you do? You can target all these three different areas, right? When the BP is high, you can try to reduce the stroke volume. You can try to reduce total peripheral resistance. You can try to reduce heart rate, right? So you can give beta blockers if you want to reduce heart rate. You can give diuretics, ACE inhibitors, angiotensin II receptor blockers if you want to decrease blood volume, as a result, decreasing venous return and decreasing stroke volume. Or you can give, again, these drugs which will decrease total peripheral resistance. Some of them will decrease blood volume. Some of them are direct acting vasodilators, calcium channel blockers, alpha-1 blockers, and other dilators which will dilate the arterioles. So you can use different type of drugs depending upon patient factors. And sometimes one drug doesn't work. You have to give a combination of 2 or 3 drugs. Okay? So much about hypertension. And then we talk about atherosclerosis now. Arteriosclerosis is abnormal thickening and hardening of the artery walls. The smooth muscle cells and collagen fibers enter into the inner layers or tunica media, tunica intima, sorry, making it stiff and narrowing the lumen. And lipid deposition may be present as well. This is known as arteriosclerosis. This is overall generalized narrowing of the arterial lumen. Okay, it happens in certain diseases, not very common. Atherosclerosis, on the other hand, is a very common disease. It is a type of arteriosclerosis. There's also narrowing of the arterial lumen, but in this case, it is not generalized. It's not all over the place. It is at specific points, okay, where you have development of a plaque, which I will explain later. So soft deposits of intra-arterial fat and other variations depending on the severity of this condition. And it is the main cause of coronary heart disease and cerebrovascular accidents or stroke. This is a normal artery, thick muscular coat, right? And this is the lumen. And this is an artery which has atherosclerosis. Look at the lumen. Lumen is narrowed. And it is not narrowed equally from all sides. So there is a bulge coming from one side, which is causing narrowing of the arterial lumen. All right. Now, normally, when the blood is flowing through an artery, remember you have laminar flow. There is no turbulence. Blood flows in a streamlined fashion. When there is an occlusion or this atherosclerotic plaque, the lumen becomes narrow. When the blood is flowing from here, you can imagine that there would be turbulence in the flow. And the velocity will increase when the blood is flowing from this narrow region. How atherosclerosis begins? Why do you have this hump-like structure within the arterial lumen? The most accepted theory about atherosclerosis goes like this. So there is endothelial injury. The endothelium of blood vessels is a very, very smooth layer. The reason for that is in the blood, you have proteins which can cause clotting. You have clotting factors, right? And normally, blood doesn't clot when it is flowing in the blood vessels. Only when there is an injury to blood vessel, there is a break of endothelium and the collagen becomes exposed. Those proteins, when they come in contact with collagen and tissue factors, they will form a clot. And platelets will also form a platelet plug there, right? So smooth endothelium prevents that. Clotting will not occur. Platelets will not adhere. When there is endothelial injury, it leads to inflammation in the local area. Inflammatory cells will migrate to this area. Neutrophils, macrophages, they will try to clear up the inflammation, okay? But the inflammation may become worse which will cause more endothelial damage. Macrophages who come there in order to clear the area, they may become foam cells, they become very big and they stay there. Endothelial changes could lead to platelet aggregation because it's not smooth anymore, so platelets will attach there, form a platelet plug, and also vasoconstriction leading to decreased blood flow. Okay, now the macrophages which are here and who become foam cells, they also release growth factors which stimulate smooth muscle proliferation. Smooth muscles and collagen migrate over the fatty streak, forming a fibrous plug. So the first thing is that there is endothelial injury for some reason, and presence of LDL is a factor, low density lipoproteins, which contain lipids. So these LDL, they enter beneath the endothelium where they become oxidized. They become oxidized, LDL. Then monocytes will come here, they will enter inside. Once monocytes leave the circulation, they are called macrophages, right? These macrophages will try to eat up all the oxidized LDL particles, and in doing so, they may become what is known as the foam cells. So these are macrophages filled with oxidized LDL particles, okay? After a while, when these foam cells are there, they release a lot of chemical factors or chemokines, which will then invite more inflammatory cells to come there. They will also cause proliferation of the smooth muscles. And these smooth muscles can then migrate and actually come into the lumen of the artery and form a cap over this plaque. What causes damaged endothelium? There could be many factors. All right, hypertension itself can cause injury to endothelium. Smoking is one factor. Hyperlipidemia, where you have high LDL levels. Okay, toxins, viruses, immune reactions, all of them can cause endothelial injury. So fatty streak means you have these macrophages filled with lipids, foam cells, and you have more inflammatory cells coming here. That's it. The smooth muscles have not proliferated and covered the plaque yet. So initial stage is called fatty streak. Now this is mature plaque now. So this is all the the fat which is here. The smooth muscles, they migrate on top and form what is known as a fibrous cap. So it's a collagen and smooth muscles together forming a fibrous cap on top. This one. Okay. Now the problem with this cap is, first thing, it is impeding the blood flow. So blood flow is no longer streamlined, there is turbulence. And because of trauma of blood flowing over this plaque can rupture. All right, yeah, so this is the next step. You have rupture, form a clot, right, which can then dislodge and become an embolus. Dyslipidemia. What does it mean? It means that there is a metabolic disorder which is characterized by increased concentration of plasma cholesterol and triglycerides. VLDL and LDL are bad cholesterol or bad lipids because they can release lipids. So HDL has a protective function. It picks up lipids from the circulation, brings them back to the liver. Liver can recycle them, use them for some constructive purpose. But LDL and VLDL, if they have higher lipid content, it means those lipids will be released into the circulation. And if you have too much lipids in circulation, if there is endothelial injury, these lipids can then get oxidized and the whole process of atherosclerosis can begin. Now, how does atherosclerosis present clinically? Would it be local manifestations or systemic manifestations? Mostly localized effects. There could be partial obstruction of an artery. This could lead to transient ischemic events. It can occur more during stress or exercise because when the tissue demand of oxygen increases, there are more chances that you will have this ischemia, right? Further obstruction, if there is complete obstruction, could lead to infarction of the tissue which this artery is supplying. Manifestations depend on vessel involved. If it is coronary artery, it would lead to myocardial infarction. If it is cerebral artery, it would lead to stroke. There could be peripheral artery obstruction. This is associated with pain and disability, especially in lower limbs. How do you manage atherosclerosis? The first thing would be similar to hypertension: modify lifestyle, diet, exercise, etc., etc. So control diabetes, hypertension if it is present, improve serum lipids. If LDL is high, your target is to bring it down and bring the HDL levels up. Aspirin may be indicated in certain cases. So aspirin basically inhibits platelet aggregation. That's all about hypertension and atherosclerosis.